My name is Dr. Dalal. I'm an orthopedic surgeon at Sierra Pacific Ortho, and today we're going to talk about some new treatment options for knee pain. So we're going to talk a little bit about what I call the common patient. This is someone that's been active throughout their life, maybe someone who had an ACL tear or a meniscus tear in their childhood, or like a football injury during sports. There are lots of folks with that, and a lot of these patients end up in their later years, maybe 2-3 decades or 4 to 5 decades down the line with a lot of knee pain, and that's really the result of arthritis. 1 in 3 people with a history of an ACL tear, whether it was treated with an operation or without, will have signs of arthritis on an x-ray in 10 years. 40% of people with a ligament injury or a meniscus injury will develop some kind of arthritis in the future. So what is a meniscus tear? The meniscus is this cushion structure right here. It's this C-shaped cartilage. And what it does is it functions as a shock absorber for your joint. When the shock absorber is damaged, it can't do its job properly, and so a lot of the times we just have to trim it out. But that has an effect on your cartilage and how your knee works. It increases the stress between the bone, and this bone, and once that stress goes up, you start to break down the cartilage. These are cartoon pictures of knees. This knee on the left is what we would call a healthy knee. There's no breakdown in any of the cartilage. The cartilage is smooth and white and is a very low friction surface. When they malfunction and the cartilage starts to wear down, you start to get these craters and potholes and irregular surfaces which create pain when you move around. And that is osteoarthritis. This ligament that you see going across the knee here, that ligament is the ACL, and tearing the ACL increases the shear force between your 2 bones, your femur here and your tibia here, and once that shear force goes up, that's very bad for the cartilage. That's why ACL tears result in arthritis a lot of the time. So what to do? Clearly, prevention is the best method to, keep your knees as long as possible. And prevention means keeping your body weight low is a huge factor. So every pound of weight that you carry is transmitted to about 5 pounds of force in your knee joint. So the only thing that has ever been proven to stop the progression of this is weight loss or weight reduction. That probably has the biggest, most important role. So we'll go over some of the treatment options. We'll start with physical therapy. Physical therapy is probably the least risk thing you could do. It doesn't involve anything going into your joint or getting into the knee itself. You're not taking any pills. And physical therapy can be effective for some people. Specifically, the only sort of evidence-based physical therapy regimen that I came across is this thing called the NEMEX or NEMX protocol. It's neuromuscular training to kind of retrain how you use your muscles in your knee. And it's not easy, right? It's a very difficult, involving protocol. It's an intense 12-week PT program 2 times a week, and it should be done under the supervision of a physical therapist. I mean, I looked at the protocol myself. I would have a pretty hard time trying to do that myself, and I understand medical terminology, right? I wouldn't be able to do it. So turmeric is, it's a spice. It's something that's found in a lot of Indian cooking, for example, and it is thought to have an anti-inflammatory property. And some studies have suggested that it may be, equivalent in action to ibuprofen. Now, that's one study. It's one small study. I'm not saying that you should stop taking all your ibuprofen and start taking turmeric. And I bring that up because a lot of people take glucosamine and chondroitin. And, of all the things out there, this probably has the least data to suggest that it works. The American Academy of Orthopedic Surgeons, every so often they create these guidelines for treatment of several conditions, and the American Academy of Orthopedic Surgeons says this doesn't work. And there's a lot of good evidence to back that up. So, I would say maybe don't take this. I don't think it makes a difference. It didn't do anything for you. There you have it. And the next one is injections. I'm sure several people in this room have had injections. So the most common injection, and the one that you can get most readily, is a cortisone shot. So what is cortisone? Cortisone is an anti-inflammatory. If you think of anti-inflammatory pathways, molecular pathways, it's a chain, it's a cascade. And cortisone stops that inflammation cascade very early. Aspirin and ibuprofen stop it kind of somewhere in the middle. So if you stop a process early, you have a bigger effect in biology. So if you stop the process early and you put all the medicine right where it needs to go, in your knee, you can make a big difference in someone's pain. One potential downside to cortisone, too many cortisone shots can actually be unhealthy for the cartilage. So if you have arthritis, it may speed up the process of your knee wearing down if you get too many of them. What's too many? I think you probably shouldn't get more than 4 shots a year. I think more than 4 shots a year is too many. The gel injections are it's a naturally occurring molecule that everyone has in their body right this minute, and the gel shots just give you more of it directly into your knee. It's proven to work about the same as cortisone. It's never been proven to be more effective. But for someone that's tried cortisone and wants to try something else, the last kind of ditch effort before they have their knee replaced, it's a reasonable option. The nice thing about the gel injections is it doesn't have that potential drawback of cortisone, where you don't have to worry about the gel injections hurting your cartilage. It doesn't work in that way. So PRP. PRP is a natural substance. So PRP is derived from a patient's own blood. So what it is you have your blood drawn. Your blood is then put in a centrifuge which spins it really fast. This separates the components of the blood. And what gets injected back into you is something called platelet-rich plasma. It's a layer of cell and proteins in your own blood that is thought to have anti-inflammatory properties that could help arthritis. And in my last position, I had the benefit of participating in some clinical trials, and one of them was on PRP. And the PRP injection worked well enough that the company, which was sponsoring the trial, elected to give every person in the trial a free injection. So whether they were in the dummy injection group or the treatment group, because that's how they run trials, at the end of the trial, they gave everyone an injection. So I think PRP works. I think it makes sense. It makes sense how it might work. And in terms of safety, you can't get any safer than something that was in your body to begin with, right? So in terms of safety, side effects, allergic reactions, that's probably not going to be there with PRP. So stem cells. Stem cells are cells that exist in your body in several locations. They exist in your bone marrow, they exist in your fat cells, and what they do is that they have the potential to create pain-relieving proteins. Extracting the stem cells can be done in a couple ways. One way people can do it is to take it from your bone marrow, which involves using an ultrasound and a needle that goes into a bone, so it's kind of painful. But recently there's been a technique to get the stem cells out of fat tissue. So usually the trunk gives you a good location for that. And you know, after extracting it, there's a kind of an elaborate process with tubing and syringes, and you can purify some stem cells from this and inject that into the target joint. Stem cells is a very hot treatment right now. It's kind of like orthopedic Botox. The one thing about stem cells that you should really know is that it cannot actually regrow your cartilage. So that's what everyone wants. They want an injection that brings their cartilage back to make their knee feel like it did before they had arthritis. And there's just nothing to support that. There's nothing to support that actually happens. So if that's what you're hoping for, I'm sorry. That's just not what they do. They probably work as an anti-inflammatory. So CBD it's a molecule called cannabidiol. So people shorten it by calling it CBD. It's derived from a cannabis plant, the same plant that creates THC, which is what people smoke and get a high with. But they're two totally different molecules. So there's no intoxication or high with CBD. So CBD has been approved by the FDA for the treatment of seizures. And there are some actual prescription drugs that can be CBD based for the treatment of seizures. And they're approved in very high doses, so 300 milligrams. A lot of the stuff that you can buy over the counter, they're just not that concentrated. So a lot of them have a lower concentration of CBD. So it's very hard for me or any doctor to really tell you how to use it. Right now, I think most patients are just doing a trial and error. But there is a way for it to work. Your brain, your lungs, your muscles, your spinal cord, all of these parts of your body have a receptor or a place for the molecule to bind, right? So it's going to work. We probably just don't know how and at what dose. So I think it's a fascinating thing. What's driving a lot of the CBD enthusiasm is people that just want nothing to do with narcotics and opioids, which I think is positive. I think opioids are definitely the wrong treatment for a chronic musculoskeletal condition that can be treated and fixed rather than tolerated and lived with. So that covers the non-operative realm of treatment for knee arthritis. And we're going to talk a little bit about surgeries. As far as surgeries go, knee replacements are very good, in terms of how long they last. Anywhere from 97 to 98% of knee replacements done now will last for 10 years. Total knee replacements, not partial, total. How happy are patients with it? Very happy. About anywhere from 85 to 90% of patients report that they're satisfied with their knee replacement. and that their life is better without it. But there is kind of an unsolved population in knee replacement. About 1 in 5 patients, so a little higher than that number that I quoted. It depends on what you read. The number for people that are happy or not can be 16 to 20%. About 1 in 5 patients, if you just wanted to do like a man on the street quiz, 1 in 5 patients with a knee replacement may not be happy with their result. And you can say 4 out of 5 ain't bad, or you can say, well, why is 1 in 5 patients not happy with this? You know what? And these are patients that don't have a problem with their knee replacement. They don't have a problem with the x-ray. You know, they don't have an infection that no one knows about. The knee works reasonably well, but they're just not happy. They don't like it. It doesn't feel like their knee. There's a couple of reasons that have been thought. One, the knee doesn't fit right, or it doesn't fit the patient. It may fit right, you know, it may be a well-done surgery, but the patient doesn't like it. And the other reason why it may not be satisfactory is improper kinematics. So kinematics is the study of how things move. And knees are actually a pretty complex joint. They're not just a simple hinge. They don't just, you know, go back and forth. There's a lot of rotation and motion that occurs that makes your knee feel like your knee. There's a little bit of pivot. There's a little bit of backward and forward rotation, motion, and then there's the bend, which is probably what people think of the most. So, how many people in this room are average? Does anyone believe in their heart that they're average? No. Okay. Good, we got that out of the way. The average knee replacement is designed to fit the average person. Which doesn't make sense. Right, so no one in this room is average, right? We're all extraordinary. And so what does that mean? So the average person is usually decided by a bunch of measurements of knees of people that are taken, and you know, a database is formed. Sometimes these measurements are taken with CT scans, and you get a bunch of numbers and dimensions, and based on those numbers and dimensions, a team of engineers will decide how to curve the implant, how big to make it, how many sizes to make it in, and that's the way that the majority of knee replacements are made. So when you take this average of many numbers and you apply it to a person, there may be imperfections, right? There may be an area where the knee is too big, where it should be a little smaller, and there may be areas where it's too small, where it should be too big. And in this schematic, that is demonstrated by these red areas, you know, areas where there may not be a highly conforming fit. So kinematics is the study of how things move. So here is a video of how a very common and popular knee replacement moves. So it bends, and then the knee kind of rolls, right? So in the normal native knee, when you bend your knee, the top part, this femur, is supposed to roll backwards. It's supposed to shift back, and that allows you to have a natural feel when you bend your knee. But over and over, a lot of studies have shown that when artificial knees bend, when people bend their artificial knees, what actually happens is this thing reaches a certain point and kind of slides forward. It does the opposite of what you want it to do. And that can feel very unnatural. You know, when you've had 65 years of your knee working one way, and all of a sudden it does the opposite, it probably doesn't feel right. So how do you fix these problems? Well, you have to make them a knee that looks like their own knee, a custom knee. You can have a knee that's made to fit you by getting a CT scan first. That CT scan takes a scan of your knee from your hip to your ankle, and all of the instruments are 3D printed to fit you. So that kind of goes over the design rationale of how these things are put together. I want to show you this video. So remember I was telling you how knees bend and sometimes the femur goes forward when it should go backward? So they do these pretty cool studies where they x-ray someone while they're bending their knee. This is an x-ray of someone with a custom knee. And this, you're looking at the side of the knee. This top part's the femur, the bottom part's the tibia. And it just shows you what happens when the knee bends. It does what it's supposed to. It rolls back when the knee goes in, and that really helps it get that last bit of flexion that it needs. People want their knees to feel normal because they want to do things. And the only way to address some of these issues is to create something that is more personalized. So the accuracy of the implants, so far in my experience, have been really, really good. I've never seen two of them that look identical. If I saw that, I'd be like, well, maybe it's not really custom. But I've never held and felt one that looked exactly like another one that I've done. I've honestly just never had one where I'd put it in the knee and said, this doesn't fit at all. They've really figured out how to make the implants fit just right. So if you want to think about it kind of in a simple way, the difference is like an off-the-rack suit versus a suit that you had custom tailored. The one that was tailored with measurements probably fits you a lot better. So patients want something that makes them feel good and want something that feels like their own. So that's kind of my journey in this process of doing knee surgery, and I think it has made a difference in the patients that I've treated with it.